allow us to switch back to Deb Cook, and I'll tell you a little bit about Deb while I push the switch over to her. Deb is Director of Health Services at the Kennett Public Schools in southeast Missouri. Kennett is due south of St. Louis, and it's west of Nashville, north of Memphis in the Boot Hill section. Deborah's been a school nurse for 16 years. She's been the project manager for various grant programs, including Creating Asthma Linkages in Missouri and Readiness and Emergency Management in Schools. She's worked with the Missouri Children's School Health Program along with several other school health program grants. She's a past president of the Missouri Association of School Nurses. And with this, we'll turn back to you folks.
Hi, and welcome to the webinar. I'm glad you've joined us today for this important message. First, I'd like to tell you a little bit about myself and the district I work in. The school district I work with is located in the Boot Hill of Missouri and is known for poverty. The district is located in a small town in Dunklin County, a county which actually ranks 112 out of 114 in the Kids Count report. 56% of our student population is Medicaid eligible. There are 5 campuses in my district. 1 is an early childhood, 2 campuses are elementary level, and there is 1 middle school and 1 high school campus. The town is located in the middle of a large agricultural area, which results in additional environmental issues with crop chemicals, including aerial spraying, and even the burning of wheat fields in the fall and the spring. Prior to 2006, the school nurses would begin the year by reviewing the medical concerns noted on student information forms. If the parent had marked asthma, we would talk with the student, and if they did not know what an inhaler was, or if they did not carry an inhaler, we didn't ask any further questions. My thought was basically that if they didn't have significant enough asthma to warrant an inhaler, then it wasn't necessary to be spending time working on the asthma action plan. But for children who did carry an inhaler, we would spend time developing an asthma action plan, which had very little usable information. If the child wheezes, use an albuterol inhaler. If there's no improvement, call 911. This met a state requirement to have an asthma action plan on file for all students who carry an inhaler at school. If a student in our district did have difficulty with their asthma, we would follow up with the parent and inform them the child was having to use their rescue inhaler. We'd make sure that they had access to a quick relief inhaler, and we would discuss inhaler use, but that was really the extent of our involvement. For many years, though, I had attended asthma education sessions at conferences and meetings. I had listened to the information about the projected percentages of asthma severity and just thought the presenter did not know my area and the projections did not apply to my district. It is projected that of the students who have asthma, 30% have intermittent asthma, 30% have mild persistent, 30% have moderate persistent asthma, with 10% having severe persistent asthma. I remember commenting to a person that the presenter just did not know the Boot Hill and did not know that we did not have that many with persistent asthma. I just did not feel the projections were correct for my area and my district, and I was sure about it. But in 2005, I was informed of some interesting data. Actually, it was shocking data to me. Dunklin County, the county in which my district resides, was #1 for pediatric asthma hospital admissions in the state. Taking into consideration there is only 1 hospital in this small rural county in the Boot Hill of Missouri, that was a huge red flag to me. When I considered the size of other hospitals in Missouri and that our small 100-bed hospital was #1 in pediatric hospital admissions for asthma, I was devastated. As a school nurse who thought I was a strong child health advocate, I'd been a failure in this area. I knew at that point that we had to start approaching asthma differently. It was obvious there was little communication about complications with asthma in my district between the school and families. At that time, I began to implement the steps in my district that the asthma presenter had been encouraging school nurses to do for 10 years, the steps that Ben and Lani have both mentioned today. Peak flow monitoring, assessing the medication students were on, identifying their triggers, inhalation technique instructions, and education. My attitude when presenters discussed peak flow monitoring was that there was no one in my area doing peak flow monitoring. The physicians never mentioned it, and none of the students had a peak flow monitor. But when I began to address this issue, I learned that actually the only reason the local pediatricians were not using peak flow monitors was because they did not think the children would have access to them due to the cost. The physicians did think they would be valuable if the children were using them. Digital peak flow monitoring is simple and quick. All of the nurses in our district quickly became fans of assessing students using the digital peak flow monitors. In 2007, the nurses in our district began taking a different approach in assessing students with asthma. We began the process slowly. We identified the students who had noted asthma on their student information forms. Those students were given an additional form for the parent to complete, asking additional questions about their asthma. Initially, only a small percentage of the students returned this form, but we began the assessment process with those students. We prioritized the students using this assessment form. If they indicated on the form they were waking up at night due to coughing or using their quick relief inhaler medication frequently, we moved them to the top of the list to assess their FEV1 and PEF. If the student did not return a form, we talked with the student and then assessed their FEV1 and PEF. We also completed an asthma control tool assessment on a large percentage of the students, which gave us some very important information about the student's asthma. We compared their FEV1 and their PEF with their predicted values using the chart provided. We assessed their severity and control according to the EPR3 guidelines. If they were in the yellow zone, which is the 60 to 80% of the predicted, or the red zone, which is less than 60%, we began working with them on inhaler technique and assessing which step treatment they were currently on and what step treatment they should be on according to the EPR3 guidelines. We found as we talked with these students, as we assessed their asthma severity and control and communicated with parents and their physician and utilized the EPR3 guidelines, that many of the students saw marked improvement. Their FEV1s improved and their frequency of use of their quick relief inhaler decreased. As noted in this chart, a student's FEV1 improved from less than 60% to greater than 80% after only 3 months on an inhaled control, on an ICS, an inhaler technique instruction. He was a different child at school. His quick release inhaler use became infrequent. This also resulted in fewer visits to the nurse's office. One teacher commented over and over to the building nurse on how excited she was about the change in one student in her classroom. We had learned he had been sitting up at night to sleep and required a nebulizer treatment during the night, resulting in inadequate sleep. He frequently missed class to go to the nurse for his quick relief medication. After a few months of being on the correct medication and using good inhaler technique, his symptoms improved, and his teacher reported that he smiled more in class, his grades improved, and he was enjoying class and recess like the other children in his classroom. That was some of the best news I could have heard at the time. What we learned by proactive case management astonished all of the nurses in our district. We had several students with moderate persistent asthma that we previously had no idea their asthma was a problem. It was alarming to me to see how many children reported they were not having difficulty with their asthma, but their FEV1 values were actually in the yellow or red zone. I think this was a red flag to all of the school nurses in my district. After appropriate medications and inhaler technique instructions, they would often comment on how they didn't realize how bad they were until they were breathing good. We learned that frequently the problem was the student did not communicate with their physician about their actual symptoms they were experiencing, because they thought how it was just asthma. That's just how they should feel. They didn't realize they did not have to feel like they could not participate at the same level as other students, that they should not be waking up at night coughing, or that they should be able to climb stairs without having difficulty breathing. All of the school nurses became great advocates for students with asthma as they began to see the difference that assessing asthma and utilizing the EPR3 guidelines made a huge difference in the lives of these children. I would also like to make sure I note that my prediction that asthma was not a problem in my district was absolutely wrong. The statistics we currently have is the percentage of students diagnosed with asthma is approximately 18%, which is also almost twice the average percentage for the state and national percentages. So there's many individual stories of success of improving a student's asthma control I could share with you. I'm embarrassed to say that I thought I was a child health advocate prior to 2006, but actually I was only advocating for what I wanted to acknowledge and address, advocating for what was easy and required little change. There is one success story I think had the most impact on me. I was notified by a building-level nurse that a parent had sent a note to the school stating his twin kindergarten children did not need to go out at recess from November to March due to their asthma and the weather. Keeping children in from recess was one of my pet peeves. As school nurses, we would all agree that children need some activity during the day, especially 5-year-olds, and cold weather should not keep them inside. The temperatures in our area of the state during those months could range from 15 degrees, which is unlikely, to 80 degrees. That time period has a huge variance in temperature. I could not imagine any reason for the children to be kept in from recess for a week, much less 5 months. So the battle was on. It was the practice in my district that for a child to stay indoors during recess, we required a note from the physician. The local physicians knew we preferred all children go outside unless it would be harmful for the child. So the physician told the father of the twins she would not write the note he requested. The father was very angry and called the school very upset. I talked with the father, and his anger only grew when I told him I did not see a reason for the twins to stay indoors all those months. He informed me his children had asthma and they went outdoors for recess. And if they went outdoors for recess, they would end up in the emergency room, and then he would have expensive medical bills to pay. I agreed to assess the twins' asthma and get back with him. At that time, when we assessed their asthma, they were both in the red zones. The problem was they did not have a control medication and frequently were out of quick-release medication. I talked with the father again, and I learned he was currently working at a new job, and the health insurance was not in effect for the children. Asthma medication for the children would have been in excess of $500 a month. So I met with the father at the physician's office, and we discussed alternative solutions for the situation. We were able to get controller medications for the twins. The twins would stay in 4 weeks until the controller medication had time to begin helping the asthma improve. This was a compromise for the situation. The father agreed for the family to receive education on caring for asthma. We worked with the twins on inhaler technique, and we saw improvements in their FEV1 and PEF. Prior to us working with the twins, they were frequenting the physician's office and emergency room and creating medical bills their parents could not begin to afford. It was overwhelming to these parents who were too proud to ask for the help needed. They were working to make ends meet, and although they knew the children needed their asthma medication, they chose the alternate to keep them indoors because the indoors seemed to be what triggered their asthma. They thought they were doing what was best for their children. When I first learned about doing peak flow monitoring in school, I was not an early adopter. As I said earlier, the physicians in my area were not doing peak flow monitoring, so I didn't see any reason for the school nurses to do it. I remember asking Dr. Francisco, do I not need a doctor's order to do peak flow monitoring at school? His quick reply was, Deb, do you have an order to take a student's temperature? This made me feel small, but he was absolutely correct, and it made the wheels of progress start. At the same time we began implementing our asthma care program, the state school nurse consultant saw the need for school nurses to become proactive case managers of students with asthma and included required outcomes of a school health grant out program to include asthma case coordination plans. This program began many school nurses in our state on a path to providing quality asthma care, including peak flow monitoring. With the results we have seen doing assessment of students with asthma, I now look back and wonder what I was thinking. I, like many school nurses and parents of children with asthma, thought I knew enough about asthma. I am not sure why I didn't see the importance of assessing asthma the same as I saw the importance for assessing glucose for diabetics or checking a blood pressure for a student with hypertension. For a student who is entering your office with asthma symptoms, measuring their FEV1 would be like measuring their temperature if they were ill. It should be the part of assessment for students with asthma. It is now our standard procedure in our district to do FEV1 and PEF on all students with asthma at the beginning of school and at the beginning of the second semester. Then, during the semester, we monitor any students who were in the yellow or red zones and provide device technique instruction and education. We assess their control. We have learned the importance of being a community of asthma care. We follow the EPR3 guidelines, and our local pediatricians follow the EPR3 guidelines. With the parent hearing the same message from all healthcare providers, it begins to make a difference to the parent also. We started slow on this, and we built each year to improve. It didn't happen overnight, but it has been a success in caring for our students with asthma. Every nurse in our district would tell you monitoring FEV1 makes a huge difference in the care of asthma for students. During my career as a nurse, I had witnessed others using an inhaler with the deep, quick inhalation, shake the inhaler, and take another hit. The in-check dial is one of my favorite resources. It allows us to teach people the correct technique for using their inhaler and actually practice with them. It was great to get students interested in their liters per minute airflow and their target time. Why would we give a child an expensive inhaler with much-needed medication in it without instruction on how to correctly get the medication from the inhaler all the way into the lungs? Assessing device technique and providing instruction is important. Some students report to the nurse's office at the beginning of the day to assess their FEV1 and PEF. It is quick and simple, and it allows the student to have feedback every day from the nurse to encourage compliance with their asthma medication. Students need frequent, repetitive information about asthma, device technique, target times, and triggers. Teaching students self-management behaviors has become our routine. The in-check dial is a very affordable resource tool for all school nurses. Be sure you know the EPR3 guidelines and communicate with primary care providers. Assessing FEV1 provides objective data to share with the student, parent, and physician. We follow a few quick, simple charts of the components we use frequently. It's important to build a relationship with the parents and the healthcare community. Using the EPR3 guide as a guide when discussing asthma care provides evidence-based information for all. So this is a simple form we use to do the communication, to provide that communication with the parent and with the healthcare provider about the student's asthma, about their assessment while they're at school. This is just another part of that tool that has the stepwise approach, that we frequently look at the steps the student is currently on and what steps they may need to be on. Students can utilize an online asthma program called Impact Asthma that allows the student to learn about asthma while assessing their knowledge of their asthma. The students have loved the program and learned the important messages about asthma that it provides. Another part was important for our local physicians to learn about the EPR3 guidelines. We found that they welcomed the education and wanted to know more, and it's allowed us to have a continuity of care for our students, for all of us to be on the same page about the EPR3 guidelines. It's also important to provide asthma education for everyone. I find most people have the same attitude I had about asthma. I thought I knew about asthma, and there wasn't anything additional I needed to know. It was an obstructive airway disease that the patient takes their medication, and that's all they need. I had no idea how much difference assessment and following the EPR3 guidelines for management could make in the life of a child with asthma. A crucial part of our program was linking to resources. In Missouri, we have asthma champions for sure. They are great resources for asthma care in Missouri. We have the Missouri Asthma Prevention Program, the Children's School Health Program, Asthma Ready Communities that Dr. Francisco mentioned, and the Missouri School Asthma Manual. School nurses will need to look locally and at the state level for who the asthma champions are in your state. I frequently hear school nurses comment they don't need any more asthma education or that they have heard enough about asthma. So I'm compelled to ask, do you do FEV1 on your students with asthma? Do you have standing orders for albuterol, 2 to 6 puffs for students needing quick relief, or encourage their asthma action plans to include the 2 to 6 puffs of albuterol as noted in the EPR3 guidelines? I'm hoping that all school nurses become asthma champions for the students in their district. Thank you. I'll turn it back over to you, Steve.
Deb, I want to say a great thank you to you for putting a real face on asthma in schools. This has been a delightful presentation for all of our folks. I'm really pleased that we can open up and be close on time despite the technical headaches that I've run into here, but we can move to inviting folks to ask questions for a few minutes if they would like. And likewise, if you folks have questions you want to ask each other on the faculty. You should be able to now type into the screen. I notice I'm fading. Sorry about that. But if you type in the question answer piece, we'll have our faculty available for a while to answer questions. And again, thanks to everyone who's joined us. There's been almost 500 people signing in that we are aware of. We have a number of questions that I'm having difficulty opening up. Can you see the questions coming through, Lani?
No, they're only going to be on your screen, Steve.
All right, well, let me try to get a couple of these. Well, definitely, folks, will be able to get a copy of the PowerPoint. You'll be able to print from our screen if you come to the ashaweb.org webpage. Question, is there a survey like this, or can this be used for students who have not been diagnosed with asthma? Would anyone like to tackle that one?
I'll give a stab at it. I'm not sure which survey they're referring to, but there are surveys done for epidemiologic purposes to assess asthma, whether or not a student's been diagnosed. But in general, from a school-based standing, it's not recommended to be attempting to do asthma surveys at school because of the difficulty of then getting a full assessment as to whether or not the student really does have asthma. If you're concerned about a respiratory problem with the student, better to get them to the primary care provider where they can do a full assessment, or an asthma clinician, so that a full pulmonary function study can be done. What do you have next, Steve?
This one's a pretty easy one for Ben Francisco. Ben, somebody's been trying to reach you about the Asthma Ready program. What is your contact information?
Let me give you a phone number. That may be the best thing. 573-884-8629.
All right. Here's a question that says, I have some children who do not have a peak flow meter of any kind. How do I get one for them?
This is Lani. A couple of possibilities that you could explore. First of all, talk to someone in your state asthma control program. Every state health department should have some kind of office. Some are more extensive than others, and they're generally the best people to identify where you can get free or low-cost inhalers in your community. Oftentimes, chapters of the American Lung Association or the Allergy and Asthma Foundation of America may be a resource. Frequently, physicians can get materials from pharmaceutical reps, but it does vary from community to community. So your state asthma program are often your best resources. Ben, do you have any other suggestions?
I think you've touched on the big ones. Those are the organizations that we would turn to. I do want to point out that two things. One, that the electronic meters are pretty inexpensive, and you only need one to serve a lot of students. So for the sake of care at school, $50 or less will get you a reliable electronic meter that will measure FEV1 and peak flow, and then you have a cost of less than 50 cents per student, which hopefully is affordable at least for those students with the greatest needs. I do want to point out that checking peak flow may be compared somewhat to checking urine sugar. When you're spilling sugar into the urine and you can detect it in the urine, it's a very late finding for diabetes. And for asthma, peak flow is relatively insensitive. It's certainly helpful for students who are currently demonstrating low peak flows or those who've had life-threatening events. But EPR3 guidelines are clear that not every student with asthma needs a peak flow meter, and that we should think about this on a case-by-case basis and ask the question, will this be helpful? There are studies that suggest peak flow monitoring at home may not help self-care for students with asthma. We certainly don't want them to be so sick that that number is often low. So it's more of a stopgap measure than an ideal monitoring system.
We have an interesting question related to the initiative of this children. This person says they find it difficult to access peak flow on students because they want it to look bad so that perhaps they'll be able to go home. How do you get students to give their best try?
That is a challenge that we come across. And I think that, you just have to note the poor effort, talk with the child, and address it individually on an individual basis. But just coaching the child to do the peak flow right, obtaining their personal best, and working with them. But that's just one of the challenges we have as school nurses.
Okay, how do you look at preschoolers? I have many 3 to 5-year-olds with asthma, and some even have inhalers. How do you evaluate and work with that age group?
This is Ben. I'll pitch in. Prior to the age of 5, the expert guidelines for assessing asthma severity and assessing control are symptom-based largely. So you're looking at how frequently cough or wheeze or shortness of breath is present, whether a child seems impaired, unable to run and play like other children, cannot sleep through the night, those kinds of things. So I think it becomes more of a functional assessment. I do want to talk a little bit, though, about the pattern of asthma in younger children, and it's really underscored by frequent respiratory infections. Many of these children are on antibiotics for respiratory infections that really are the common cold that they just can't clear from the airway. So frequent need for antibiotics is a warning sign when it's being used for the treatment of respiratory symptoms. So I think that's helpful. The guidelines are also clear that if you have to keep using oral steroids to manage periodic attacks of cough or wheeze or shortness of breath, more than once a year is too much. So having to be on oral steroids 3-4 times in a year underscores the existence of asthma, and it's far safer to use a daily inhaled corticosteroid. And I think one of the messages to parents is that when we use oral steroids, this is 1,000 times the dose that's being swallowed and systemically absorbed. So whereas this is an effective therapy, it's not an optimal therapy, and there are many side effects, including weight gain and interference with bone metabolism and some long-term risks related to cataracts and other things. So I think that we want to look at the whole picture and say, is this child experiencing a pattern that suggests asthma?
Okay, I have a question specifically for you, Deb. They want to know your ratio of nurses to students in Southeast Missouri.
We are fortunate there. Our ratio is about 1 to 500 in our district.
And another question directly to you is, how did you communicate directly with students' primary care providers? Did it require special permission from their parents?
We do communicate directly with the providers, and yes, we do get a consent sign to have that communication. When we start working with the student, and usually we just reserve that for the students that are having difficulty that we're assessing frequently, we will talk with the parent and ask for permission, a signed release form for us to talk with their physician. But we have found it to be very beneficial. There have been several cases where when we talk with the physician and we provide their FEV1, their symptoms, how they're doing, the physician will make medication changes, and then we monitor that, communicate back with the physician, and those students have improved. And so as time has gone on, we've seen more and more medication changes based on our assessment at school and providing that information to the parent and physician. So I think it is very important to get that consent signed so that you can communicate with the physician.
Okay, I think this is maybe a more generic question to the physicians. Do most insurance carriers cover the tools to take the FEV1?
And the answer is no. When you measure airflow, if you are going to be reimbursed for it, it requires full spirometry with a printout that shows airflow graphically and with measurement of small airway flow. So FEV1 measurement's not reimbursable. Inhalation instructions is reimbursable. Every insurer in the state of Missouri reimburses for that. Currently, we are not billing from the school for that service. We hope that will change in the future and have reason to believe that it will.
Very good. Deb, another specific one to you. You're popular today on these questions. Did you make your own asthma assessment communication tool?
The form that I showed on the PowerPoint, we did create that, but we used some information that we found on internet, a trifold brochure that had some of the EPR3 guidelines on it, and then we just created the information on the left. I'll be glad to share that form with anyone who would like to contact me for it.
Okay.
I'd also add, Steve, that on the Missouri School Asthma Manual, it can be found online at the Missouri Department of Health and Senior Services website, and it has many valuable forms in it that we use frequently.
Okay.
And as Dr. Francisco mentioned, they can just Google Missouri School Asthma Manual, and I think it will bring that up on the Internet.
Okay. I'd like to also point out, and this is one of our folks has reminded me, that we will be placing updates on Facebook and Twitter for the American School Health Association when the programs are available on our webpage. Another question is, are there other opportunities for on-site trainings regarding the Asthma One devices?
This is Ben again. We have produced some web-based training that goes over the use of the equipment. We have a 20-minute program that really is designed as a review for people who are school nurses who are receiving their equipment in the mail and want to get the devices out and play with them and think about them before they use them with students. And I would be happy to share that link with you, Steve, so you can make that available to folks.
Excellent. We have everyone's email because they're registered, and we'll be sending out additional information that Ben and Dr. Wheeler and Deb may provide at the same time that we're asking you for some more evaluation. Another question, and it looks like we can go for about 10 more minutes if that's okay with the faculty.
Sure.
After working out in physical education classes, how can I, as a school nurse, help students differentiate between being short of breath from exercise and the need for a rescue inhaler?
I'll take a stab at it. I know that Lani has thoughts as well, I'm sure, but a couple of things stand out. One is recovery time. We all get short of breath when we are exerting ourselves. If we're not physically conditioned, that happens sooner and it's more marked. But remember that asthma makes it difficult to empty the lungs. And so when you look at the character of breathing, people with asthma work to exhale. You may or may not wheeze. We say sometimes when I squeeze, I wheeze, which means when I'm trying to push trapped air out of my chest, there might be a sound. That's distinct from vocal cord dysfunction, where the noise is actually stridor and it corresponds with breathing in. So a student who is working hard to exhale and who does not recover from physical activity within a few minutes, and a student who benefits from the use of albuterol, and remember albuterol takes about, its peak effect is about 40 minutes, and we would need about 20 minutes to fully assess that response. Those are all strong signs. When someone has rested 5 to 10 minutes, rechecking their FEV1 is very helpful, and seeing drops greater than 10 to 12% with exertion would suggest that the asthma is not well controlled or that, in fact, this is asthma.
Okay. Another question, and I might turn this to Lani. Do you have specific guidelines for schools on what you would consider a life-threatening asthma condition?
Certainly. Assessing that child's symptoms as well as their airflow obstruction are two good indicators. Certainly if a student is having so much difficulty that they're using accessory muscles to breathe, if they're showing signs of cyanosis with lips or fingernails turning blue, if they're having difficulty speaking so that they cannot speak in full sentences, those are all indicators of a severe asthma episode that would require as much immediate treatment as available. Many students with asthma may also have allergies, and in emergency situations, many students' lives have been saved when they were having so much respiratory distress that their allergy protocol was essentially implemented, and they were given an injection of epinephrine, usually by an EpiPen, to address an emergency circumstance.
I assume this is directed to Deb. Deb, can folks get a copy of the forms that you used in your presentation? Would you share that with folks through us?
Yes, I'd be glad to.
Okay.
Not a problem.
Okay. And this question is the more technical, back to the meters again, folks, is how do you clean the digital meter so that many students can use the same device?
The two components of cleaning, one is surface wipe with an antiseptic that would air dry. So it's hand-to-device contact, so we could spread germs from the device to the next person. The mouthpiece that we showed on the slide is a one-way mouthpiece, so you can blow into the device, but you cannot breathe back from the device. So that's the protection against the spreading of respiratory particles.
Okay. How important is auscultation in assessing children at school?
This is Ben. I'll offer some initial comments. Listening to the chest can be helpful, but wheezing is not going to tell us a great deal sometimes about the condition of the child. There are children with severe asthma attacks who do not wheeze, and children who are in no distress but who are wheezing. So wheezing is a physical finding associated with asthma, not to diminish its importance, but I encourage you to look at the character of breathing. And as asthma progresses, the work of breathing out increases. So normal breathing, we take time and effort to get air into the lungs, and outflow of air is spontaneous and effortless. So having to work to push air out, spending more time exhaling than inhaling is very helpful. I do also want to mention that when someone's having worsening asthma, there's often asymmetrical findings, so you may have diminished airflow on one side versus the other, or airway secretions or noise on one side. And after an albuterol treatment, 20 minutes after an albuterol treatment, those findings may reverse. If they do not reverse, then that's worrisome. And it might indicate just more severe airflow obstruction, and it might indicate pneumonia, but in either case, failure to have the lung fills clear and open after treatments would be a sign that we would want to a finding we would want to report.
Okay, another interesting question in the schools. I have many students with orders to use their albuterol inhaler prophylactically prior to PE. What's your opinion on this practice?
This is Lani. Studies have indicated that as many as 90% of school-age children with asthma are likely to have exercise-induced asthma, so that pre-treating with albuterol, it can be very appropriate to minimize their symptoms during physical activity, and of course we want them to be active. This type of treatment does not count against asthma control. You may recall that I pointed out that albuterol being used for symptom for treating symptoms is the indicator that's measured, not the prophylactic preventive treatment. Ben, did you want to add anything to that?
No, I think that covers it well. Thank you.
Okay, another question. I have students that doctors have instructed to do 10 breaths in and out instead of doing deep breath in and hold for inhaling the puff. Is this a correct technique?
I'm going to jump in there and say that would be an odd instruction. The goal is to generate that 30 liters of flow and to go from empty to full of air and medication in the target time. If this is a 3-year-old, you won't be able to do that, but you can coach the 3-year-old to blow out their old air before you push down on the inhaler, and a 3-year-old should have a chamber with a face mask, and then you would say, breathe in, breathe in, breathe in, hold it, hold it, hold it. Very simple phonetic way of explaining that you're going to gradually fill the lungs and hold that air momentarily. But I don't know of any 10-breath method that's effective.
This is a little similar to one of the others that you had, but I think I'll throw it in anyway. It's like I have students who use inhalers daily as a routine before recess. Is this safe, effective, or recommended?
I'll add one thing to what Lani said, and that is that in the real world, there's an awful lot of people with persistent asthma that's untreated. And the only time they really know they have a problem is when they're going to run hard or play hard, and they're very limited. So my concern about people who need albuterol before every type of physical activity, even moderate to light play, is that they really have untreated persistent asthma. And the rest of the story is that we have many students who once used albuterol every day before exercise were diagnosed correctly and put on appropriate medications and now seldom need to pre-treat because they can do what they want to do without any limitation. And the reason is the inflammation is gone after a few weeks of daily ICS use, which must continue to maintain that state. But to summarize this, the reason people have trouble when they run and play is that the mast cells that line the respiratory tract have stored excess amounts of prostaglandin, histamine, bradykinin, leukotrienes. So the bullets are in the gun, and when you start running, those chemicals are released in the airway and they cause a bad effect. So for some folks, the solution is get on the right medication regimen, get those cells back under control so you don't have inflammation, and you'll have a reduced need for albuterol, and you'll have better tolerance of physical activity.
I want to do one last question, and then I'll say thanks to folks who will be at the top of the hour. If parents are not open to the school nurse's concern about poor asthma control, is it ethical to speak directly to the healthcare provider?
I guess you'd have to look at the severity of the child and how it's impacting the child. A lot of times I find that just in the case with the twins, I really needed to take a step back and look at the bigger picture and find out why the parent is not wanting the information. What are the barriers? You know, is it maybe it is a financial issue, and so there's many reasons that you can come up with. But when it comes down to if you're concerned about the safety of the child, then I think you have to look at maybe it's a neglect issue. But I think as school nurses, sometimes we jump too quick to, because this has been how I've done many times, is we're quick to say the parent just doesn't want to take care of their child or they don't want to do what they need to do. But a lot of times we need to step back and figure out why they're not doing what they need to do and how can we approach it differently to convince them of the need for the care for the child.
Thank you, Deb. And once again, thank you, Dr. Wheeler and Dr. Francisco and Ms. Cook. This has been, your presentations have been extremely valuable, and I only apologize for the technical quality of our first webinar. But with that, we will be turning to close. Please watch your email for information from the American School Health Association. Visit our webpage. This will be available hopefully in a week to download and share with other folks who do healthcare within your schools. And I hope we see a lot of you folks in Louisville. I've learned to say Louisville and Missouri in the same hour. Thank you very much for your attendance and for your attention. And thank you, faculty.